Hello, and welcome back to my wound care channel. This is Doug, the wound care guy. And man, what a backdrop on this video. I have had such consternation with regard to this video. This video is about diabetic wounds, diabetic ulcers, more specifically of the feet. And so I've studied this. It's a heavy thing to try to get across in 15-minute video. I'm going to do the best that I can. But I had set today aside for it, and family members showed up, which was lovely, and we had a great time, and a great dear old friend did show up as well, which was quite glorious. And so we sat around today, and you know, God has His plan, and I think that was part of the thing that I would have forgotten to express was the Maillard effect, or I guess you call it the Maillard effect, or something along those lines. We're going to get into that in a second, but I probably wouldn't have included that in this video, so I'm kind of glad that it all worked out the way that it did. And so I'm hoping to share with you now, with a clear mind, hopefully, how what's going on with a diabetic wound. And I'm not going to get into the whole thing of diabetes, because diabetes is like a major, deep discussion. There's so much that goes on in diabetes and diabetic ulcers, and there's so much cause and length of time that the disease process is, basically occurs over several years, decades maybe, in many cases. Many people have had diabetes for a decade before they're even diagnosed, and I don't want to get into all of that. I just kind of want to get into the basics about the diabetic ulcer itself. So let's talk about what a diabetic ulcer is, and I'm just going to hit on a couple of key points as far as the pathophysiology of a diabetic ulcer. So we're not going to get too deep in that, but what is a diabetic ulcer is, what causes it, what does it look like, and how the heck can I prevent amputation? And I don't mean to be grandiose about this. I do have a little slide that I'll show you in a little bit here that shows that, man, there's a lot of diabetics that wind up getting an amputation, and it breaks my heart if I see, especially if I have a patient, they have to have a amputation. I feel like I didn't do my job, but the problem is that much of the disease destruction has occurred over so many years that once you receive the patient in your clinic and with the wound and what have you, it's far along the way of tissue destruction, and sometimes you just can't get it back. It's super unfortunate. So let's get back to what causes a diabetic ulcer. And basically a diabetic ulcer is caused by diabetes, and diabetes is essentially a disease process where you're not producing enough insulin, or you're insulin resistant, and there's excessive amount of blood glucose floating around in the bloodstream, and that glucose over many years, when it's in contact with tissue, causes a great number of different processes that essentially wind up taking the tissue and hardening that tissue to some extent. So what winds up happening, and it'll do tendons, nerves, arteries, capillaries, veins, all of it will be affected by the high blood glucose. And it causes the tissues to stiffen. And also there's a significant amount of inflammation that occurs with the high blood glucose. And that too will cause its own set of problems for the body. So let me see if I can sort of get back to my little list here on the left. I've written some of the things down so I don't get off track, because I usually do that. Matter of fact, I almost always do that. So the cause of diabetic ulcers, in short, It's caused by prolonged high blood glucose and chronic inflammation. The prolonged high blood glucose causes damage to blood vessels and nerves of the feet, and in advanced cases, other parts of the body as well. So I've seen people with advanced diabetes and diabetic wounds on their fingers. And man, that's some spooky stuff, because that's super quick to the heart. That gets infected, the potential of going sepsis is very, very, it's a big problem. It's almost completely very likely that would occur. So that you have to be really, but I have not seen a lot of that in my career, but mostly in the feet, right? So the tissue damage to the nerves result in an insensate foot. And so we're going to sort of try to move into what is the cause. You've got the diabetes, but what is the cause of the wound, right? And then how to fix the ulcer, or how to work with the ulcer. And so part of the wound, the factors that cause the wound, is an insensate foot. So the diabetes has so affected the nervous system of the foot that it does a number of things. It reduces hair production. It reduces oil production on the skin. It causes callus development. Temperature regulation is altered, both warm and cold temperature regulation. And then, of course, sensation. Some people might be able to feel a vibration or a deeper sensation in the foot, but an insensate foot is an insensate foot. And some people have paresthesias where, there's so much inflammation and activity on that nerve, it's a hyperesthesia, meaning it's feeling a lot of pain, is also the result of diabetes. But that those people can actually sort of feel their feet, whereas an insensate foot, they're not getting they're not receiving any information from sensors in the foot or in the skin as to where that foot is in space or what is it touching. So that's kind of how that becomes a problem, because it's kind of hard to imagine, and there might be some of those out there listening to this that have that that problem going on, and they can't necessarily feel their feet, that'd be great if they could share in the comments, how that feels to them. But on my end, when I'm seeing a patient for the first time, we kind of just do a quick assessment of their sensation, and they can't, we have them close their eyes, and we just kind of poke around a little bit and tell, there's some exchange of information. Do you feel that? No, I don't feel that. We kind of mark where it was at and what they didn't feel, or if they did feel something, we'd mark where that was at. But typically speaking, they just don't feel anything. And so if you're walking along and you're barefoot, you could injure yourself. You could step on, a sharp object, or, I guess what I see a lot of people do is they sort of, construction worker folks and people like that are around construction sites, nails. They get nails in their feet. They walk around with their, oftentimes with their, shoe on until they feel the blood, I've had a couple of patients, where they like to wear flip-flops, and one of them stepped on a thumbtack and didn't recognize that there was a thumbtack in their shoe. And you don't recognize there's a thumbtack. And in that case, the shoe, like the thumbtack, wasn't significant enough to cause a lot of trauma, so there wasn't a lot of bleeding. But there was an open place on that person's foot, which, an open place is where bacteria can kind of get in. And the big picture is that you can't feel something, you injure yourself, you may not be able to feel it, and then you go on your life, and you might be going barefoot around in the house, you might be going barefoot in the bathroom, or you're barefoot in the shower when you're taking a shower, and then those areas have bacteria, E. coli, Enterobacter, Staphylococcus, Pseudomonas in the showers oftentimes. Those kind of things can kind of get into your tissue, which would bring you to the next problem. And the next problem is that you can't feel whether or not an infection ensues. And when I got certified in wound care, I found it very interesting when I found out that, you look at a normal person's wound, and if there's erythema around the wound or there's redness around the wound, we would want to measure that and know what that was. And clinically speaking, if it reaches 4 centimeters, outside of the periphery of that wound, on a normal person, we have some concern, and we're thinking that perhaps that this is an infection that potentially can go systemic. Where with a diabetic ulcer, it's back, it's half that, so it's half that size. So the concern is like we've got 2 centimeters of erythema in a diabetic ulcer, and the problem is that the person can't feel whether they've got an infectious process going on, and that's pretty spooky, right? And so you got bacterial build up and build up and build up until it no longer has any space inside the tissue, and it'll burst out and drain nasty fluids. And oh boy, by then we certainly know we've got a problem. You want to add to that, as far as the healing process goes for a diabetic, the healing process is extremely slow because, you have what's called the Maillard effect, and it's spelled Maillard, and I'm going to throw a slide in there that will show you what that means. And what that means, since this is a great time to bring it up, is that if you look at a piece of, I like to use a chicken breast analogy. If you look at a chicken breast and you pull it out of the package, and sorry for you vegetarians out there that might be freaking out at this, you pull one out of the package, it's got a certain glisten to it, it's movable, pliable, it's I don't know, it feels like a muscle, it's kind of spongy. And well, you juxtapose that to a piece of chicken that you have parboiled and, not grilled on the grill and, with sauce and everything like that, but it's sort of boiled a little bit. And you'll notice the difference of the 2 pieces of chicken. The piece that's boiled, it's got sort of, it's changed color. It's shrunk up a little bit. It's stiffened a little bit. And essentially what's happened is that the effect of cooking it has caused a change to the proteins of the muscle. And essentially of any collagen fibers at all will be altered by the cooking. And with diabetes, when you have a prolonged blood glucose, that's kind of like what you see in the tissues of a diabetic, or that's what you can expect to have in the tissues of a diabetic. And so that's where you start getting rigidity in the nervous system. The tissues are usually, when they want to be pliable, they want to be movable. Same things goes for the capillaries and our arteries. And so, when you have the infectious process, getting back to the infection, I'm so glad I was able to keep this tangent going long enough. Sometimes I get lost. But if you go back to the infection, it's harder for the body to fight the infection. And, the body won't even kind of let you know you have the infection because, first of all, you don't have the sensation. And once you really start seeing that erythema set up in that wound, you've got a big problem. And with diabetes, you need to get urgent. It's urgent. It's an urgent thing. You urgently need to get to a physician or an emergency department or something like that. You don't want to mess around with that. You can go gangrene very, very quickly. You can get a lot of bacteria get fired up very, very quickly. All of a sudden, it'll seem like, oh my God, where did this even come from? So that's the Maillard effect, and they call it. It's almost like if you were to sort of supercharge the aging process. A lot of people with diabetes will have atherosclerosis, which is it's more hardening of the arteries. The blood will get through there, but it's not the same as if everything was more normal. The other problem is that sometimes in that diabetic, you'll also have a situation where that maybe that hardening goes all the way up. It's all the way up in the leg. And so taking oral antibiotics and getting a delivery of antibiotics to the site isn't all that effective. And so it's super tenuous trying to deal with diabetic ulcers. So again, what we're having the insensate foot. We have an injury. We can't feel the injury. The injury progresses into an infection, and then we have a poor delivery system. So that's an injury. Some people injure themselves not with a sharp object or something that they've stepped on, or what have you. But they injure themselves by the way they walk. And what that means is that if you have a diabetic foot, there are alterations in the mechanics of the foot. Chiefly, and I'm not going to get into all of them because there are a lot of them, and it would take a lot longer to go through this video. But chiefly among them is the lack of dorsiflexion, D-O-R-S-I flexion of the ankle, and the Maillard effect will affect the Achilles tendon, which is the tendon that goes from the gastroc and the soleus muscle of the calf and attaches down to into the calcaneus or calcaneus, and so it attaches there. And what happens is it shortens and it becomes more rigid. And so when one walks, they're not, if they're walking along, let's just see, they're walking along. Usually, folks they strike on the heel. They strike on the heel, and so your toes are slightly up. And you're swinging your leg forward, boom, your heel comes down, and your toes are slightly up. Well, when you have a reduction of dorsiflexion, and most people, they're at neutral, so you can't even move them. Normal's, 15 degrees, let's say, of flexion up this direction as you walk. But most diabetics are almost flat, let's say. They will hit here a lot. So you have all the energy from the body coming down through this patient. And they're walking along, and all that energy is being dissipated on these smaller bones in the front and the skin underneath. And that breaks down the tissue. Oftentimes on the first digit, which we call the great toe. But also all along the base of the foot, you'll get them opened up. And I have some examples of that going forward. So that's a mechanical alteration, right? Sometimes you'll get a situation where the connective tissue, of the foot has broken down, and you'll get what we call a subluxation of a bone inside the foot, which means it just kind of pops out of its orbit, if you will, out of its spot, because the tissue that used to hold it together tightly has broken down, and so now you have an uneven surface. So you might have, the third or fourth digit bone stick down further than the rest of the foot. And of course, what's going to happen then is a lot of wear is going to happen on that tissue. And so this is an offloading shoe, which we'll get to toward the end of the video. Please stay by. This is really cool. But you'll have some malformations of the bone, or a Charcot foot where you have a large drop of the bone here of the navicular in the foot. And that's really, really bad, unfortunately. It's bad when you get to that point because it's not a good picture. And then another one that is problematic and also due to wear is callus formation. And on the pictures that I'll have later on in this video, I'm going to share some of those, some of the pictures of callus and what it looks like. Callus formation is like, you might have a bony abnormality, or you might have had an injury, or you might wear tight shoes or inappropriate footwear. And the result of that is callus formation, which means the body is recognizing there's a force up against the skin. And unfortunately, with a diabetic, one of the responses is development of significant amount of callus. That callus will build up, and it'll go into overdrive, and it'll be building up callus for days to the point where you have an abnormal amount of callus development on your foot. And what will happen is, it's almost like if you had like a marble in your shoe and you couldn't feel it, right? Because you've got the insensate foot. And you're walking around, you got this marble. And what happens is the marble is going to smush between the ground and your shoe. And then the bones are here, and the ground and the shoe's here, and the marble's here. Well, that marble's beating the heck out of the soft tissue that's in the middle. And the response of that is a breakdown of that tissue. And you can have breakdown of that tissue underneath the callus, and you wouldn't even know it because first of all, you can't feel it, and unfortunately, most diabetics are not checking their feet. like with a mirror or a flashlight or anything like that at the end of the day to check out for red spots or abnormalities or what have you. And one of the things that you'll notice is that you'll get underneath the callus, it'll get almost translucent a little bit, and you'll see it's white all the way around the perimeter, but yet it's still hard. And sometimes you'll get even a little bit of a blood tinge to it or a redness look to it. And that's trauma underneath. And you've probably got a wound underneath that callus. And, you need to come to somebody like me or a podiatrist or a physician to have that shaved off, if it's significant, and then sort of get on a regimen. But I don't want to jump too far ahead, but you want to get on a regimen to reduce that. So other diabetic, you've got trauma, which we sort of talked about, sharp objects, which we talked about, bony abnormalities of the foot, poor wear patterns on the foot, overuse on certain parts, reduction in dorsiflexion through the gait process, and then of course the callus formation. So I think that pretty much does it on that. That's kind of how you would move from I've got diabetes, I've got an insensate foot into a wound, and then moving through, hopefully not getting infected, moving through the infectious process. So we sort of talked about the Maillard effect a little bit. I'll show you a picture of that. You've probably seen it by now since I'm back. I'm going to go ahead and post those along as we go, but I'm just reading it to you now, and then I'll fill in the photographs later as we go along. So let's see if I've missed anything. I have not on that. So I want to give you some numbers here with regard to diabetes and our diabetic ulcers, foot ulcers. And I found this online, so probably a bunch of you guys could go out there and find it online too, but it's not super important other than to recognize the fact that, hey, we got a problem on our hands here. And so anyway, there's about 1.6 million new cases of diabetic foot ulcers per year. Of the new cases, up to 20% will require an amputation. 20%. And this doesn't have to be like this. This is a preventable disease. This is the thing that breaks my heart about it the most. And unfortunately, not so many of us catch it early on. We don't recognize we're diabetic. And if you don't know whether you're diabetic or not, go to your doctor and ask for an A1C. It's just a measure of 3-month sort of a snapshot of hemoglobin and what hemoglobin looks like after it's been in the presence of blood glucose for however long and however much. And I'm not quite sure how they do it all, break it down in the lab, but that A1C number will give you an idea of whether or not you're diabetic or you're pre-diabetic, insulin resistant or not, right? And you can start taking control of it and not get into this category where you're looking at an amputation. 34% of diabetics will develop a foot ulcer in their lifetime. So that's 1 in 3, right? If my lower leg math is adequate. The national cost for diabetic care can reach as much as $13 billion annually. And I don't do the numbers in my clinic. I just do the care. But some diabetic ulcers we see for a long time, like months, months and months and months. And I'll get asked a lot of times, hey, how long do you think this wound's going to be here? And I just tell them, well, how long has it been there already? Sometimes they've been there I've had patients that have had wounds for years, diabetic ulcers. Matter of fact, I treated this one person for a long time, and he had had a wound for 10 years, diabetic ulcer for 10 years. I couldn't believe it. And I don't want to get into that very deeply, but at the end of the day, diet was a big factor for this individual. So those are kind of the numbers. What are the symptoms of a diabetic ulcer? Let's talk about that for a minute. So a visible wound, usually on the bottom of the foot, ball of the foot, or great toe. lateral aspect, right on, like if this is the great toe, it's like, a lot of times it's right in here. If this is the foot, a lot of times, if this is, if this is the foot, it's along the ball of the foot, right? A lot of times. Okay, every so often on the heel. One of the things you'll notice is redness or swelling on the ball of the foot or toes. Redness and swelling is a indication that, if you're diabetic and you have redness and swelling and you don't even know how it got there, just go get some help. Go to your urgent care facility or your physician or ER or whatever. Oftentimes they'll get you started on an antibiotic, and it's usually a broad spectrum antibiotic, and that'll knock it back a little bit. And then certainly, follow up with your healthcare and find out what's going on and go after it. Purulent drainage, sometimes with odor. Purulent just means, look, there's an infection going on. The white blood cells have shown up. They're kicking some butt, but they're just getting their butts kicked too, The bacteria is maybe getting ahead of the game a little bit, especially if it's significant and it's worsening and it keeps coming out and it smells. There's no doubt at that point in time you've got a diabetic ulcer. If you're a diabetic, if you're not a diabetic and you get that kind of ulcer, but you probably wouldn't have known. The difference is that if a normal person had that amount of purulent drainage coming out, they would have felt the infectious process. That's the thing, is like a lot of diabetics just don't feel the infectious process. Sadly, they can't address it. Dark, hard tissue or callus. The reason I say dark, hard tissue, and I got a photograph with that on there. It'll get dark and hard. You can, if you have a callus for a long time and you're walking around with it, it can get dark and hard. The other thing is that if you have an ischemic condition, which is a reduction of blood flow, and that will often happen to the toes themselves, and that's common in a diabetic. I mean, that's super common. I would say less than 10% from an anecdotal perspective. From what I've seen, I would say less than 10%, but it does happen. And that would be, a gangrene look. You'd know it'd be like a mummy at the end of the toe. You could tell that it was lacking blood flow for sure. And it would be cold, typically speaking. White macerated callus that may have not opened. And so we talked about that, right? Because we said that, you could be walking along and you have this huge callus, and you look at it one day and it's sort of got that white look to it, around, and you'll see the pictures when I get those going here. You'll see the white at the perimeter. That's maceration. We call it maceration. And of late, I kind of came up with my own terminology for that, and I'm basically suggesting that that's subcutaneous trauma underneath the callus tissue, because the callus is offering the trauma to the underlying tissue. And it will have a inflammatory response, which will draw some moisture to the area. And it's not coming out, it's stuck inside. And you'll see that discoloration. So that white macerated callus. Drainage on your sock. If you're a diabetic and you've even had a wound before on your foot, wear white socks. It's super important that you have a white sock on. The reason that you want to have a white sock on is that if you have drainage coming out of your foot that you can't feel, typically speaking, it'll stain the sock, and then you'll know. It's kind of like improves your awareness of what's happening with your feet. Again, when you have diabetes and you have an insensate foot, getting any jump start on any redness whatsoever is super important. Now, if it's redness that's there one day and gone in the morning, not to worry about it. I mean, you might want to say, hey, I might need to change my shoe here a little bit, alter my footwear a little bit. You might want to do something like that if you start seeing it, regularly. But otherwise, I wouldn't freak out too much if it's a red spot that's transient. Change in sensation may be slight increase in pain in an otherwise numb foot. So a diabetic, they will feel pain sometimes. The diabetic with the insensate foot will feel pain sometimes with an infectious process, because they can feel sometimes a throb. They might not feel a heat or a cold or a light touch, but they might feel a throb inside the foot, right? And so that would be an indication that you got a problem, right? If yours is a change, it's a change. So I've got four different, pardon my jug, but man, talking like this will dry your throat out. I've got four different pictures I'm going to show you of diabetic ulcers. They're not every kind of diabetic ulcer you'll ever see, but I just wanted to get you off to a good start. But we'll come back to it. We'll circle the wagons on it and come back around to a deeper dive on diabetes and diabetic ulcers. If somebody says, "Hey, man, you didn't do this," or you didn't explain that, or whatever. Excuse me, please. Yum. Okay, so that first picture that you're going to see it's a little bit of a dirty foot. It's been bandaged. You can see there's some adhesive marking. The adhesive will draw soil to the area, so it gets dirty. It's a very, very dry callus. It's not a very moist wound. Sometimes a diabetic ulcer will be, most diabetic ulcers aren't as wet as you'd see like a venous ulcer is. But they can be pretty, they can be moist at times or wet initially, especially if there's a lot of infection. The infection with all the bacterial activity, that's where your moisture comes from a lot of the times in a diabetic ulcer. Otherwise, they may appear fairly dry. And so that's what makes treating a diabetic ulcer difficult, because if it's a dry, ulcer, you want to bring moisture to it. And if it's a wet ulcer, you want to take moisture away. We're not going to get into bandages on this one. We're going to get into bandages. I haven't figured out how I'm going to go about that yet, but I'll probably break the bandages down a little bit. But with this ulcer here, I'm gonna try to clean all that that wound away with a curette. I have curettes. I love curettes. They work really, really well. And pare away all that callus tissue. You don't want to leave callus tissue at the perimeter of the wound, because man, it's just how can you heal it? How can you heal something when the causal factor, which of course is the callus, because what does it do? It traumatizes the skin, the tissue between the skin and the bone underneath it. So that's got to be removed. And then you want to find an appropriate dressing for that foot. So, get it nice and clean and get it moisturized. At the end of the day, with the callus tissue at home, folks, you got to take care of the callus. So if you have callus, pare it down. Get yourself, what do they call those things? Pumice stone. Or, I have a file. It's got a handle on it so I can reach my heels and stuff like that and sort of keep the callus from building up. It's going to worsen as we age. It's a normal part. We get drier as we age. Anyway, those kind of things will help bring down the callus. And then you want to get a good moisturizer that's going to go into that skin and keep the skin pliable, right? And not have it build into that hard callus. The second picture is, there's a little bit more moisture there. And, you can see it's on the ball of the foot. And, you can see that translucent sort of wet whiteness to the peri-wound area. And peri-wound just means the surrounding tissue of the wound bed. And then, of course, it looks like it goes off down deep in there. And what you want to do with that one is you want to clean it out and, maybe see a podiatrist, somebody like that, or a wound care person, and really have them debride that white tissue back. And the problem with this is that, like I said before, one of the things that, diabetics do best is build callus tissue. And not just diabetics, but there are, alcoholic neuropathies, which will be similar type of a wound. And there's medication neuropathies, that can cause these things too. I have a patient that takes some medication for I can't remember exactly what's going on there, but some kind of a medical, prescriptive drug causes a similar situation, unfortunately, right? So the neuropathy is the kicker in this case. And remember, neuropathy isn't just about all of a sudden you can't feel your foot, man. There's all sorts of stuff going on with the arteries and the capillaries and the skin, and there's no moisture, and you're not developed. Your body isn't releasing oils as normal, and there's no there's no heat controls for sweating or cool, or what am I missing? No hair production. Neuropathy is neuropathy, and it's basically an environment that's being altered significantly through the lack of good nervous flow into the limb. The third photo is one of an individual who has metatarsal phalangeal wound, and NTP joint is what we call it. And you can see there's some callus around the perimeter. It looks like it's been cleaned by somebody, but you can see this wound's been here long standing. It almost looks like, the pink or the redness on the inside. It's pretty dang red. It could be inflamed. Beefy red tissue, which is what we like in a wound, looks like hamburger. And when there's, what's the name of that tissue? Granular tissue. You'll see it all bubbly and happy inside that wound bed, whereas this is sort of just, I see these often, and this is, this wound's continues to get traumatized, and the tissue that's trying to heal and close the wound is traumatized, and therefore it's not one, right? It's separated and sort of pushed apart, and you get these little islands that sort of grow, and they kind of grow up inside the wound, but like it's like, it's like two or three, oh God, what would be the term? Like I don't know. It's it's like piles or something like that. Not a pile, but what you'll get is let's say you'll get one bit of granular tissue that sort of forms into what looks like a little muscle almost, and then you'll get another one that forms, and then another one that forms. You get two or three of them that form inside that single wound bed, and it's not congruent. It's not connected. It's all disconnected. And so you got to debride that tissue a little bit, and sometimes you can use like silver nitrate just to stimulate it and sort of get it to mend together, and then of course get it offloaded well. But you can see this individual also has some bony malformation going on, probably due to the diabetes. And diabetes, again, will break down your tissues. So any number of things can happen, right? You can have a decrease in blood flow, ischemic condition in the end of the toe or the foot. You can have a breakdown of connective tissue, which causes increase or an altered wear pattern to that tissue, or it gets traumatized over and over again. So there's a lot of different things that can occur. So then we have wound number 4. And you can see that one's pretty well. It's round. You'll notice a lot of these are round, right? Because why? Underneath the area where the wound is at is a bone, right? And the bone isn't square or triangular. It's more round. It's not perfectly round. It's awkwardly round, but it's still round. And it wears down the tissue accordingly. And typically between the callus and, the bone underneath it, and the tissue in between getting smushed, versus a continuous wear of the tissue, which would break it down also, okay? In the aforementioned process where people don't have a significant or enough dorsiflexion so that they're constantly wearing down the distal part of the foot, or where your what do you want to call that? The forefoot, the ball of the foot. Well, the ball of the foot is what I meant to say. So anyway, it's round. It doesn't have a lot of erythema. None of these look like they're infected, right? And you can have a really wicked looking wound and not have it be infected, which is great. So this one does not look infected. You can see that there's some yellow tissue inside that wound bed. All needs to come out. You can see this wound, in my view, is not super old. A couple of the other ones look like they were, I would say, the first one looked pretty old. Second one, not so bad. Third one, definitely older. Getting some care too, but you can tell by that tissue in that third wound again that, it's been traumatized for a fair amount of time. And then fourthly, I think that's pretty much all I really have to say about that in particular. So what's the treatment for wounds, right? For diabetic ulcers? And before I forget, because I don't have it on my little list, is get some vascular studies done to make sure that you have plenty of blood flow down to the limb. That's a big deal. There's a lot of times where you'll have a diabetic ulcer, and your physician won't say, it won't click that you probably have or could have a reduction in blood flow to the limb. And I think that's super important to have ferreted out. Because if you have a blockage, especially if you're a smoker, the likelihood is significant that there's a blockage. And, I don't care what you put on your toe or what have you, if you don't get good blood flow and you get revascularized, chances of losing your foot are pretty good. And that's what we want to keep from happening. That's why you're watching this video, is to sort of get, a guideline. I'm not a physician, and I'm not trying to, keep you from going to see one. I want you to go see one. You're going to need help with these diabetic ulcers. Again, some places you'll go to, they just won't make the connection. They just might, but it's worth pointing out that, hey, this has been here a while. I need an arterial study, please. So it's not on my list here. It would be remiss for me to not say that. So wound treatment, improved glucose control. Okay, that's all for the evening. We can all forget about the rest of the video. No, improve your glucose control. That's huge. If you do nothing else, improve glucose control through diet. Ask your physician to refer you to a dietitian. It's a big deal. Study a little bit on the internet. Figure out what it is that's spiking your glucose. Make sure you're taking, your blood glucose daily if you're a diabetic. You should be doing that. So many of my patients don't even bother with that. And it's very unfortunate because you don't have any control of your glucose situation if you don't know what's spiking your glucose. And I might be able to eat white rice and you might not. And some people get spikes for the weirdest reasons, I've had people that have had protein, they've eaten steak, and their glucose spikes. So it's different strokes for different folks as far as the glucose goes. So improve your glucose control. You can exercise to improve glucose control as well. So expounding on that just a little bit. Exercise. Get on a stationary bike and get on there and boogie woogie until you start feeling a little bit of sweat. If you can't get on a stationary bike, you're debilitated, march in your seat at home. Try to get your respirations changed. If you can get your respirations twice what it would be at resting, that's twice the amount of oxygen you will get to your wound that you wouldn't have gotten otherwise. That's a big deal, So again, improving glucose control. You can improve it through diet, medication, and exercise. Weight training is another really excellent way of controlling your glucose because muscles feed on what? They feed on sugars. So the more bulky or the more muscle one gets, the more sugar will be consumed out of the bloodstream, which will also help control your blood glucose. Keep the wound clean with regular wound care. And man, I can't really go into that too much. It's a rough road to hoe because diabetic ulcers are so varied. As I said earlier, some need moisture brought to them, and some need to be dried up. If I see just quick and easy, if I see a wound that is a diabetic ulcer and it's super moist, me personally, I like to hit it with iodine. I found iodine just works really, really well with diabetic ulcers. I haven't done studies on it. This is all, anecdotal, but I have found that to work really, really well. And I just really like that. And then I'll put an absorbent dressing down. And then I'll wrap the foot with some Curlex or, gauze wrap, and then maybe a little bit of Coban. And, I'll usually maybe put an alginate or something like that, picks up moisture. Because we want to take the moisture away in a wet wound. In a drier wound, I would clean it up. I still might use iodine. Because it's so hard for the body to fight invaders because of the diabetic process as it affects capillaries and what have you. It makes me nervous. So I like to keep it. I like to keep iodine on my diabetic ulcers. I just do. Once they get going along the way and the patient's on the right path and we've offloaded the wound, and I'm jumping ahead of myself, but then I kind of will get away from it. I might move more to a silver gel or a honey to bring moisture to the wound, and maybe some cream at the peri wound to help continue to break down the callus formation. And then over that, I might put a Vaseline impregnated gauze or something like that, which will maintain the moisture over the callus. Some diabetic ulcers do really well with moisture. I've healed a lot of them like that. But it has to be, you have to identify what you're dealing with. If you're dealing with, a moist wound, you want to dry it out a little bit. Not all the way, but a little bit. Much of the way, especially with a diabetic ulcer. If you have a healthy person, you want a moist wound environment. But, be that as it may, we're not dealing with a healthy person. So frequent wound debridement by your MD, podiatrist, wound care specialist, okay? Get control of you got to have debridement of the tissue. And also the diabetic ulcers respond really well to serial debridement. So it's kind of like you're re-educating the local environment. Hey man, we've got a problem here, with the trauma of debridement. Sometimes you nick the patient. That's the way it goes. The tooling isn't perfect, but that little bit of blood being invited from the trauma, so long as it's clean, you're cleaning up that wound, that will create an inflammatory response from and it's an acute inflammatory response, which is different than a chronic wound. A lot of time, one of the things we want to do to bring a chronic wound into the acute phase, so we can get all that proliferative stuff going, so we can get some good healing. So when you kind of, cause a little bit of bleeding, even just a little tiny bit, you get that cascade, right? And that re-educates the body. Hey, we got a problem here, folks. We need to get some capillary readout, fill in there and try to get some blood flow to that tissue so that we can get some granular tissue development. And it takes a while, but I do think that is the case, anecdotally, okay? And that's not a scientific study. Offload the wound to promote healing. So this is a Darko boot. I'm not affiliated with Darko or anything like that. I just use them a lot. At the end of the video, if I have time, I'm going to go ahead and go over this Darko boot. Actually, you know what? I'm just going to do it right now. Darko boot. I'm going to try to speed this up a little bit. It's adjustable. It's got straps here that are all Velcro. The point of the Darko boot is what? We have this insert. And this is just a Darko boot. There are a lot of other ways of offloading a diabetic ulcer or a foot, right? There's rocker bottom where you have a roundness here and it rocks and it dissipates force. They have some with just a big heel and you're out on a ledge here. That offloads the front. Some of them have, it's more bulky here and it offloads the heel, this area here, so that when they walk, they're not hitting their heel. But in this case here, we've got this insert, and what happens is I usually have my patient wear the shoe for a couple, 2 or 3 days, because when they've come to me, they've had the ulcer for a long time anyway. It's not like it's going to be the end of the world. This is softer than most people's shoes anyway. So they'll wear this a couple, 2 or 3 days, and they'll create a wear pattern in or on this, and then I'll just flip it over, and inside here are removable little pixel-like dudes. See that? And you can just pop one of these dudes out, or 3 or 4 or 5 of them, or however many. And then, hopefully that's where the wound is going to be loading up. And then you put this peel stuff on the backside of your insert. And now you have decent kind of a surface that offloads your wound, and then it goes inside of your happy little boot. Pretty cool, right? So that's a Darco boot. There are others by other names. I'm not affiliated with Darco, as I said. Just wanted to show you this since we're in the offloading phase or discussing offloading. And there are other ones too. There are casts and lots of, front wheel walkers, canes, knee scooters, whatever you got to do to keep weight off of a diabetic ulcer. You're not going to get it to heal if you step on it. It's simple. Take my word for it. You're going to have nothing but issues. Okay? Darco boot. Okay, what else? Offload, we got that. Protect the wound from contaminants while showering. A lot of my patients come in and they've been told to just keep showering with a wound on their foot. And I don't have to tell you, I don't have to give anybody a physics lesson. If you're watering your body, you're taking a shower, you got water coming out, it's hitting your head, it's running down your body, it's going through your crotch, right? And it's going into the water that's pooling in the shower. And there, it's a 50-50 chance at the very least that you're going to get a bacteria from your body inside your wound. So, the first thing that you want to do is control that. When I do a wound, when I'm doing wound, I want control of the wound environment as much as I can get. And I ask my patient, I said, look, don't shower anymore without a cast cover on your foot. And a cast cover, you can get them online, you can get them at your local pharmacies. Your large stores probably have them. I don't think grocery stores and things like that, I wouldn't expect them to be there. But you can get a cast cover, look it up online, or have somebody look it up online for you. And you want that on your foot or on your leg when you go to take a shower. And try not to get your bandage wet. Okay? So we want to, in that case, interrupt a vector of infection to the limb. And once we get that wound nice and clean and debrided and what have you, and then we maintain a good environment, an appropriate environment for that wound, and we're not getting the dressing wet and it's that kind of thing. You're gonna, and you offload it, control your blood glucose. You're gonna head toward healing your skin, your tissue. And then again, if you smoke, do what you can to stop. Do what you can to stop, because each cigarette that you consume, roughly plus or minus, well, mostly plus. And what I'm saying is that it takes a good hour for that, the effects of the cigarette. It constricts the blood vessels. It, pretty much in the bottom of your lung, you're getting significant development of CO2 and carbon monoxide. It's kind of hanging out in your body, and you're not moving it out, right? And you're encumbering the oxygen from getting onto the hemoglobin and move around in your body and get to pull the CO2 out of the body. So there's a little bit of a round trip that happens in the lung that's going to prevent you from healing. The longer that your wound stays open, the more likely it is to get infected. And so, you gotta bring everything to bear to get that thing to close up, because some people can, get an infection in their bone, and that's when we start losing limbs. That infection is, that wound won't heal, and we're not exercising, we're eating cupcakes and smoking cigars, probably going to wind up, unfortunately getting, an amputation of some kind. So tips for prevention: inspect your feet daily. Inspect your feet daily. If you work on your feet all day, inspect them at the end of the night. Get a flashlight if you have to look at them. Get a mirror. Put your foot on around the mirror. Whatever, however you want to do it. Have your loved one help you look at it. Take a picture with your cell phone and look at it. Whatever you got to do. To get get an idea of what's happening with your foot regularly. Wear good shoes that support bony abnormalities. Certainly I recommend that once you do get healed, that you see an orthotist and you have a shoe insert made that offloads your bony prominences. And that's a big deal, because going forward, you don't want to continue to break down your tissue because of a bony abnormality. Inspect your shoes with eyes and fingers. Do a sweep. Make sure there's no rocks, little tiny stones, whatever. Check the bottom. Make sure there's no sharp objects sticking through your shoe. Don't go barefoot if you have poor sensation, because you're not going to feel trauma. You're not going to feel heat. If the pavement's hot or the concrete's hot, you're going to burn the heck out of your feet. Be mindful of that, okay? Avoid having feet in a wet shoe for any length of time. That will cause maceration of the tissue. It sort of gets white and sort of weird looking, and it's easy to tear your skin or cause the callus tissue that you may have to rip right off, and boom, you've got a wide open wound. Moisturize your skin regularly. Okay, we want pliable tissue, and we want to break down the callus. And one way to break down that callus and to get because you're not making oil. That's part of that whole process of not having good localized, nervous tissue. Your nervous tissue is dysfunctional because of the diabetes, and so you're not creating oil. Bring oil to bear. Put it on your foot. Address callus formation with a pumice stone, as we talked about. Keep an eye on any discoloration that may last more than a day, and bring it to the attention of your physician. If it's 2 or 3 days and it's getting worse, go to the ER. You got a problem. You got a diabetic. You don't want to mess around. You're diabetic also. You don't want to mess around. Or if you're a diabetic, you don't want to mess around with that kind of discoloration, especially if you start feeling something. That could be an infection. You can do that just by stubbing your foot if you're diabetic. It can be that bad. If you have a wound on your foot of any kind, seek medical attention as soon as possible. I think we beat that horse pretty well. Well, that's pretty much all I have for you on that. I hope you had a great time. I'm trying to reduce the length of these videos, but I don't think it's going to work. I didn't really go into the pathophysiology at all on this, and there's a lot to learn, but I think that's enough. I think that's enough for most people out there, and hopefully it's just a way of helping you navigate the medical system to improve the outcome that for yourself or your loved one. If there's any way that you think that anybody might need this information, forward it to them. Give me a thumbs up. That way, the algorithm will bring me to more people. And my goal is to get this information out to many people as possible. I've been called to do it. I don't want to sound ridiculous, but I have been called to do it. I want to get this information out and disseminate it to as many people as I can. Well, with that, have a great day or night or whatever it is that you're doing. And again, I'm going to shoot out another video as soon as I can, and I hope you return and check it out. And leave me a comment down below and let me know what you liked, what you didn't like, and anything you might like to see in the future. I'd certainly go ahead and try to produce that information for you. Okay. Thank you so much. Bye-bye.